So I want to start with the Prometheus model, which I'm going to attempt to do in 3 slides. And if any one of you out here are familiar with the Prometheus model, that necessarily means we're just not going into all of the detail, just highlights of the detail. The Prometheus model is being piloted in 2 phases. A retrospective approach with the reconciliation done at the end, and a phase 2, a prospective approach. But the basic structure for the model itself is similar in both cases. So the Prometheus model is set up to cover several different episodes of care, both acute and chronic. The acute hospitalization conditions like pneumonia, for example, cover a pre- and post-surgical time frame, and chronic conditions such as asthma. So those are set up, again, as a period of time, 1 year. And a series of inpatient and outpatient procedures or acute episodes, some of which involve a portion of an inpatient stay, like pregnancy and delivery. That's why it's listed as outpatient, but we recognize it involves part of an inpatient stay. So pregnancy and delivery covers an 11-month time period. It's a 9-month look back and a 2-month post-delivery. An important aspect of the Prometheus model is that all patients or a particular participating provider with that particular condition are required to be paid using the model. So this is to avoid the potential cherry picking of particular patients with the condition. So the first step is to determine an evidence-based or an evidence-informed case rate, or the ECR. And that's based on the costs of the typical care. So what are the costs that are associated with the services that are determined to be the best practice services based on accepted clinical guidelines? So then they add to that a severity, and that's for the actual patient in question. So this takes into account certain patient demographics, age, comorbidity. Then there's plus a margin, a profit margin, which can be adjusted by the payers. In this case, it's 10%. Plus what we're calling a PAC allowance. This is a potentially avoidable complication allowance. There's a very complicated method to arrive at what the PAC allowance is, but it's designed to allow for some portion of the cost of a potential complications to slightly offset the cost of the corrective treatment if they do occur. But what it essentially does is it creates a strong incentive to avoid complications altogether in order to retain more of the. So how does that work? Let's take an example of a hip replacement surgery. The typical cost of care that includes, all the appropriate services as determined by the clinical guidelines with no adverse event is determined in this case to be $15,000. This particular patient is of an advanced age and has some comorbidities, so it requires a severity adjustment of $3,000. So the severity adjusted cost of typical care for this patient is $18,000. At this time, the profit margin piece is set at 10%, so that's added to it for $1,800 additional. A small allowance is added for the potentially avoided complications, the PAC allowance, to be used to offset the complications if they do occur. But this is applied to all patients. The PAC allowance is included in the ECR by just using a percentage of the costs that are associated with complications as found in this historic data for that condition. And then it applies a percentage as a flat fee. So in this case, $480. This particular piece of the bundle payment, I think, is an important negotiation point. Just what that PAC allowance should be that sort of appropriately balances the incentives for, providing quality care. There's an additional amount, too, called the proportional rate that's calculated by taking into account the volume of cases and the total costs of the care. And again, greater detail on this can be found in that report that was published this Friday. So the result here is a total PAC allowance of $1,740, and then a total evidence-based case rate for patient A equal to $21,500. In phase 1 of the Prometheus pilots, the PAC allowance is built into that case rate. In phase 2 of their pilots, those PAC funds are put into what they refer to as a PAC pool, and it's used to offset some of the costs of the complications should they occur, but only a small proportion, of course, of the costs. But it's also used to provide the quality bonuses, the explicit quality bonuses, and we'll talk more about that in a moment. So we know what the payment for the episode will be, $21,540, but how the money gets dispersed depends on what happens. And here we illustrate 3 different scenarios for our patient A who underwent hip replacement surgery. Under scenario 1, the total cost of the hip replacement surgery and its related pre- and post events was $30,000. So this may or may not, probably did, involve some complications in some way. So that was $8,480 over the case rate, the original case rate, and this would be absorbed by our provider. In scenario 2, the actual costs were just slightly over the case rate, and in scenario 3, the actual costs were $18,000. Remember, that was the base severity adjusted case rate, assuming no complications. So that's $3,540 less than our final established case rate, which builds in the PAC allowance and other things, of $21,500. So in this case, that $3,540 becomes savings to the provider. And this plays out a little differently depending on which phase of the pilot we're talking about. In addition to this, there are quality measures that are built into the Prometheus model that creates bonuses for quality performance that come out of that PAC pool that's created from the unused PAC funds. Any funds that aren't paid back to the providers in the terms of quality bonuses can then become savings, essentially, in theory, for the payers or the patients. Again, the report provides more detail on this.